Welcome to Learn from the Case. Hello, how are you? I opened this channel to present some cases. I work within neurology and internal medicine, and I want to share a little of what I have and am learning. I want to comment that I work in different hospitals in different countries. I also train in different countries, so that treatments in different administrations can and will vary. It seems to me that this also helps us, contributes to our medical training. Today I'm going to talk about Chiari malformations are caused by problems in the structure of the brain and skull. In Chiari malformations, the lower part of the encephalon presses downward, so there is a displacement of the cerebellar tonsil through an opening in the base of the skull and pushing down cerebellum into the spinal canal. I'm going to leave several images here to try to illustrate what I'm saying. In minor downward displacement, less than 1 centimeter, the patient might be asymptomatic. The cerebellum is the part of the brain that controls balance. Normally, the cerebellum and part of the brainstem sit above an opening in the skull, called foramen magnum, where the spinal cord connects to the brain. When part of the cerebellum extends below this opening and into the upper spinal canal, it is called Chiari's malformation. Chiari malformation may develop when part of the skull is smaller than normal or misshapen, which can put pressure on the cerebellum, brainstem, and spinal cord, and block the flow of cerebrospinal fluid, the liquid that surrounds and cushions the brain and the spinal cord. Chiari malformation can be called primary or congenital, which is much more common and is caused by problems in the development of the brain and spinal cord that occur during the fetal time. Chiari malformation can also be secondary or acquired, and so when it develops later in life due to traumatic injury, disease, or infection. Classification of Chiari malformations. Chiari malformation type 1 is the most common form. It occurs when the lower part of the cerebellum called the cerebellar tonsils pushes into the opening between the skull and the spinal cord, foramen magnum. Normally, only the spinal cord passes through this opening. Type 1 Chiari malformation is usually first noticed in adolescence or adulthood, often by accident during an examination for another condition. The Chiari malformation type 1 is the most common of Chiari malformation. Chiari malformation type 2 involves both the cerebellum and brainstem pushing into the foramen magnum. The nerve tissue that connects the two halves of the cerebellum might be missing or only partially formed. Type 2 is usually accompanied by a myelomeningocele, a form of spina bifida that occurs when the spinal canal and backbone do not close before birth. A pathophysiological theory is that Chiari 2 malformation is secondary to a caudal myelomeningocele, producing downward traction and hence herniation of the brainstem and cerebellum through the foramen magnum. A myelomeningocele usually results in partial or complete paralysis of the body below the spinal opening. It is the Chiari malformation type most associated with hydrocephalus. Usually requires shunting for the hydrocephalus and surgical intervention for the myelomeningocele, and might include posterior fossa decompression through suboccipital craniotomy. Type 3 of Chiari malformation is a critical condition characterized by some of the cerebellum and the brainstem sticking out or herniating through an opening in the back of the skull. Membranes surrounding the brain and spinal cord may also herniate. Symptoms of this very rare form of Chiari malformation appears in infancy and can cause debilitating and life-threatening complications. Babies with Chiari malformation type 3 can have additional severe neurological defects such as mental and/or physical delays and seizures. Type 4 Chiari malformation, a very rare condition, involves an incomplete or underdeveloped cerebellum, a condition known as cerebellar hypoplasia, while the cerebellum is in its normal position. Parts of it are missing, and portions of the skull and spinal cord might be visible. People with Chiari malformation might not have symptoms initially, but might develop them later in life, as symptoms depend on the extent to which the tissue and nerves are compressed and on the buildup of cerebrospinal fluid pressure. Chiari malformation symptoms can include headache, especially after sudden coughing, sneezing, or straining, neck pain, hearing or balance problems, muscles weakness or numbness, dizziness, difficulty swallowing, breathing, or speaking, excessive drooling, gagging, or vomiting, ringing or buzzing in the ears, tinnitus, curvature of the spine, scoliosis, insomnia, depression, problem with hand coordination and fine motor skills, difficulty eating and an inability to gain weight. Signs and symptoms are mainly due to direct brainstem compression that might cause autonomic dysfunction, in particular syncopal episodes and sinus bradycardia, due to autonomic dysfunction. To be noticed that researchers have determined that the length of tonsils descent in a Chiari malformation does not always correspond to the severity of symptoms or to the response to treatment. In fact, some individuals are classified as having Chiari malformation type 0, in which there is minimal or no descent of the cerebellar tonsils. These individuals still have symptoms associated with a Chiari malformation, most likely due to abnormalities in the flow of cerebrospinal fluid between the skull and the spinal canal. Research is ongoing to understand the complex underlying mechanisms that cause Chiari malformations. Chiari malformation is associated with and can cause other neurological conditions, including hydrocephalus and excessive buildup of cerebrospinal fluid in the skull and spinal canal. Spina bifida, the incomplete closing of the backbone and membranes around the spinal cord. Syringomyelia, a cerebrospinal fluid filled cyst known as a syrinx in the spinal cord. And tether cord syndrome, in which the spinal cord movement is restricted by the tissue around the bottom of the spine. MRI is the main investigation of choice in these individuals, allowing full visualization of the cervicomedullary junction. Chiari malformation type 1 are generally asymptomatic, and at that point a condition that does not require treatment. But when there are some symptoms, the most common symptom is both in adults and child, pain and headache in the occipital cervical region. neck pain. In the very young population, a history of headache or pain might be difficult to elicit, where these symptoms are more likely to manifest as excessive crying, irritability, and failure to thrive. Pediatric patients are more likely to present with brainstem dysfunctions, sleep apnea, or feeding difficulty. The latter is due to the involvement of the glossopharyngeal and vagus nerves, resulting in an absence gag reflex and hoarseness. As the cerebellum is involved in higher cognitive functions, potential cognitive alterations have been recently investigated, and the presence of a general cognitive impairment in the executive functioning, verbal fluency, spatial cognition, language, and memory processing has been reported. It should be noted that the headache produced by Chiari malformation type 1 is often exacerbated with the Valsalva maneuver due to the reduced size in the foramen magnum or relative reduction thereof. This should be differentiated from chronic headaches that do not vary with the Valsalva maneuver, which might be attributed to pathologies other than Chiari malformation. For example, intracranial hypertension. Although migraine headache have a prevalence similar to that of the general population, in individuals affected by Chiari 1, there is an earlier age of onset and a severe clinical presentation. Magnetic resonance imaging is the main investigation performed for Chiari type 1 malformation, providing a depiction of craniocervical junction with identification of secondary complications such as hydrocephalus or syringomyelia. When you are studying a new patient with Chiari and you want to evaluate the degree of disability, can be rewarding to order sleep studies, which involves sleeping overnight in a room where they can monitor breathing, snoring, oxygenation, and seizure activity to determine if there is evidence of sleep apnea. To evaluate swallowing, you can order a fluoroscopy used to watch the internal swallowing process to determine if there is an abnormality suggestive of lower brainstem dysfunction. Brainstem auditory evoked potential is an electrical test to examine the function of the hearing apparatus and brainstem connections. This is used to determine if the brainstem is working properly. Somatosensory evoked potentials is an electrical test of the nerves involved in sensations, which gives some information about peripheral nerves, spinal cord, and brain functions. Treatment for Chiari type 1 malformation remains rather empirical. It encompasses a combination of medical and surgical approach through a multimodal dynamic strategy. The choice of treatment depends on the degree of the disability, generally confined to symptomatology, headaches, or neck pain. Non-steroidal anti-inflammatory drugs, muscles relaxants, and physical support collars might improve symptomatology. Meditation, yoga, or mindfulness therapy have also been proposed for addressing pain. Surgical treatment is typically reserved for patients who present with severe or worsening symptoms, who go on to have a confirmation of cerebellar descent on imaging, and a Chiari malformation obstructing cerebrospinal fluid flow confirmed by CMRI. Surgery aims to prevent the compression of the restricted cervicomedullary junction, allowing cerebrospinal fluid flow to be restored to optimal levels. The main approach involves performing a occipital craniectomy at the level of C1 posterior arc, C1 to 2 laminectomy, with or without associated uroplasty. Thus, this intervention indicates as posterior fossa decompression. This is the most adopted neurosurgical approach, focused on restoring the cephalospinal fluid flow across the foramen magnum. The procedure is performed in up to 99% in the literature. A minimally invasive procedure allowing resection of submeningeal cerebellar tonsillar herniation followed by reconstitution of cisterna magna without craniectomy has been proposed for addressing Chiari 1 with laryngomyelia. Among non-invasive approaches, several methods have also been proposed to decompress laryngomyelia with distal drainage to the subarachnoid space, syringosubarachnoid shunt. Chiari 2 malformation, as mentioned above, used to require shunting for the hydrocephalus and surgical intervention for the myelomeningocele, and may include posterior fossa decompression through suboccipital craniectomy. Differential diagnosis. Important diagnoses to consider in the workup of Chiari 1 are cerebellar tonsillar ectopia less than 5 mm, Chiari 2 to 4 types, idiopathic intracranial hypertension or pseudotumor cerebri, craniospinal hypotension, basilar invagination. Prognosis. Surgical outcomes are favorable, with 73% of patients improving less than 1 year postoperatively and 79% at 1 to 3 years at follow-up. Posterior fossa decompression induced symptoms improvement in about 2 to 3 of individuals, especially in those without associated laryngomyelia. Complications. The most common postoperative complications are cerebrospinal fluid leakage and pseudomeningocele formation. The latter might require revision surgery or shunt insertion. Other complications include aseptic or bacterial meningitis, vertebral artery injury, and epidural hematoma formation. Postoperatively, patients might experience headache and neck pain due to the operation. Neck exercises might be given to aid the return of full mobility as soon as possible, as soon as it is able. Patients typically return to work in 4 to 6 weeks, with a follow-up MRI performed at around 6 months to 1 year. Full recovery from Chiari surgery might take months or longer. It is important to slowly increase activity in a graded manner, avoiding any strenuous lifting in the early phase of recovery. While the genetic origin of the malformation requires more confirmation, the malformation can occur in several defined genetic syndromes. However, it is not always clear whether the observed associations are real or random. Those genetic syndromes are especially craniosynostosis, pteumopathies, and rosopathies. I hope this video has caught your attention. This presentation is entertainment for students and health professionals who want to listen to studies, discussions, or clinical cases. It is not intent in any way to replace the learning provided by reading medical literature or the experience provided by clinical practice.